Yes, ma'am. It's visible.
It's visible now?
Yes, ma'am.
Yeah, thank you so much for
Welcome.
inconvenience again.
1 second, ma'am. Ankita, ma'am, Vandana, ma'am.
Yes, ma'am.
Can she start the presentation?
Yeah, she can start. Only 15 people have joined. If the other people also join, it will be good.
Okay.
Anyway,
ma'am.
you start.
Okay, ma'am. Ma'am, you can start the presentation.
Yeah. Good afternoon, all. Actually, today my general club presentation is on does advanced paternal age affect outcome following assisted reproductive technology, a systemic review, and a meta-analysis. A total of 1 in 7 males in UK are estimated to be affected by infertility, in which 30% are due to male factor and 25% of which are unexplained. Figures in England and Wales have demonstrated that fathers aged between 35 to 54 years accounted for 40% of live births in 2003, compared with only 25% in 1993. Am I audible?
Yes.
With childbearing increasingly delayed, it is crucial to understand the potential consequences of this for men as well as women. The adverse conditions most consistently associated with increased paternal age, musculoskeletal syndrome, cleft palate, acute lymphoblastic leukemia, and retinoblastoma, and neurodevelopmental disorders in the autism spectrum and schizophrenia. Already I told you the topic of my journal, that is, does advanced paternal age affect outcome following assisted reproductive technology, a systemic review, and a meta-analysis. The authors are Sugashini Murugesu. Do I need to tell all the authors' name, ma'am?
Not required. Which journal, from which journal have you taken this? That has to be mentioned. Dr. Anjum?
Yes, ma'am. Hello?
Yeah, you have to mention which journal you have taken it from.
This is
And
from
the
reproductive
impact factor.
online.
Impact factor of the journal, all those things you have to mention actually.
Is volume 5. It is published in 2022. It was this.
Dr. Anjum, your voice is breaking.
Audible?
It's audible in bits and pieces. I think your network is an issue.
One minute. Huh? Yeah, my network is okay, ma'am.
Okay,
This journal is from Reproductive Biomedicine Online, ma'am. Volume 45, second issue, and which is published on April 9th, 2022.
Okay.
So now coming to section A. The population study include 28 studies selected according to preferred reporting items for systemic review and meta-analysis, that is PRISMA guidelines. Data were extracted from these studies to collaborate cycles separating paternal age at 30, 35, 40, 45, and 50 years, that plus or minus. The intervention is following ART treatment the effect of paternal age on a wide range of reproductive outcomes was studied. A literature search was performed using the PubMed, Medline, and Google Scholar database from comparative study up to and including June 2020. The primary outcome of interest were clinical pregnancy, live birth, and miscarriage rate. The secondary outcome were the number of fertilized egg, cleavage stage, embryos, and blastocyst, and embryo quality per cycle. This is a systemic review study, and the study investigating the effect of paternal age on ART outcome between 1995 and 2020. It's a meta-analysis which was performed according to the preferred reporting items for systemic review and meta-analysis, that is PRISMA Statement 2020 Checklist Guidelines. A literature search was performed using PubMed, Medline, and Google Scholar database for comparative study up to and including June 2020. The objective of the search was to investigate the clinical significance of increasing paternal age on fertilization rate and pregnancy outcomes in ART. The following medical subject headings, search headings were used, that is increased plus paternal age plus IVF, paternal age plus IVF, paternal age plus ICSI, paternal age plus fertility treatment plus ART. The related article function was used to broaden the search, and all citations identified were reviewed, irrespective of any language. No studies investigating the effect of paternal age on ART outcomes were found before 1995. Therefore, the relevant studies were found between 1995 and 2020. Non-English studies were not included in this study. The inclusion criteria is included where all comparative studies evaluating the effect of different paternal age groups on ART outcomes and reporting the incidence of pregnancy outcome. IVF treatment with or without ICSI was included in the meta-analysis. Studies that defined paternal age groups with cutoff at 30, 35, 40, 45, and 50 years were included. In order to allow the standardization, those studies that reported a cutoff within a year of specified paternal age group were also included. That is 30 plus or minus 1 year, 35 plus or minus, up to 50 plus or minus. The exclusion criteria excludes those studies which are not reporting pregnancy outcome as a rate per cycle were excluded. Finally, studies where the paternal age group were separated by more than 1 year of specific age cutoffs as described were not included in this study. Using these strategies, studies comparing ART outcomes across different paternal age groups were identified, and data regarding the outcome of interest were extracted. Where 3 reviewers independently extracted the data from each study. The following data were extracted like first author, year of publication, study design, study period, study country, and study group. Quantitative data and assessing fertility related outcomes were also extracted like fertilization, cleavage, top quality embryo, clinical pregnancy, live birth, miscarriage, congenital malformation, and birth weight. Inclusion and exclusion criteria as well as paternal age group cutoff as per each study were collected. So now coming to the search result on PubMed, Medline, and Google Google scholars. First, the search result where the increased paternal age plus IVF was 42 studies. The search result where paternal age plus IVF were 127. The search result where paternal age plus ICSI plus ICSI were 103 studies. Search result where the paternal age plus fertility treatment was around 147, and the search result where paternal age plus ART was around 80. So total number was 499, where potentially relevant records were found. From this, the title in was 499 in number, where the number were excluded based on title was alone 379, from which 300 were irrelevant studies and 79 were repeats. Total abstract included 120 studies, out of which 74 were excluded after reading abstract and full text. And from that, total 74 were irrelevant studies. The full text include 43 studies where abstract data was available for only 3 studies. Full text article excludes from meta-analysis where there is 18 studies included systemic review. No relevant data was present with relevant T included in meta-analysis where 46 studies were initially identified, out of which 28 studies published between 1995 and 2020 were selected for meta-analysis according to the stated selection criteria. The primary outcome were pregnancy rate, live birth rate, and miscarriage rate, and the secondary outcomes were fertilized embryo rate, cleavage system embryo rate, blastocyst rate, and number of quality embryos were studied. These findings were started from the following paternal age cutoffs: 30, 30. The statistical analysis was the odd ratio was used as the summary statistic to assess the effect of a particular age cutoff for each study. Consequently, all estimated odds ratio for a given outcome and age cutoff in the relevant studies were pooled to ensure the comprehensiveness of the analysis and maximization of the statistical power. In addition, sub-analysis were presented by type of effect measure, namely odds ratio within the subgroups of studies, treating the journal population as the reference. The I2 statistic and the chi-squared test of heterogeneity were used to assess heterogeneity of treatment effect between studies. The degree of heterogeneity was categorized into low, that is 25%, into moderate degree, that is 25 to 75%, and high degree, that is 75%. Both fixed effect and random effect models were used to calculate the pool treatment effect in each meta-analysis. This study was done in 2015 and 2003 by Der Simonon and Ledard Higgins et al. Data were analyzed using statistical software release 16 in USA, and the result was regarded as statistically significant if P is lesser than 0.5. His paternal age where cutoff is 35. 10 out of 28 studies reported on overall pregnancy rate at the paternal age cutoff 35 years in autologous oocyte cycle. The incidence of overall clinical pregnancy is significantly greater if the paternal age was lesser than 35 years, that is 40%, and if it is 32.6% for more than 35 years. Live birth rate in autologous oocyte cycle, that is paternal age cutoff 35 years, five studies reported at the live birth rate per treatment cycle in autologous oocyte cycle. The incidence of overall live birth per treatment cycle is significantly greater if paternal age was lesser than 35 years, and that is 35.3% of live births, and 24.5% if paternal age is more than 35 years. Miscarriage rate in autologous oocyte cycle, the incidence of miscarriage rate per cycle pregnancy per clinical pregnancy were not significantly reduced if paternal age was less than 35 years, that is 21.7%. Clinical pregnancy rate in autologous oocyte cycle is 12 out of 28 studies reported on overall clinical pregnancy rate at a paternal age cutoff 40 years in autologous oocyte. The incidence of overall clinical pregnancy at paternal age were significantly greater if paternal age was less than 40 years, that is 44%, and 34.5% if paternal age was more than 40 years. Live birth rate in autologous oocyte cycle. 6 of 28 studies reported the live birth rate per treatment cycle in autologous oocyte cycle. The overall incidence of live birth per treatment cycle were significantly greater if paternal age was lesser than 40 years, that is 28.4%, and where it is only 17.6 if the paternal age is lesser than 40 years. Miscarriage rate in autologous oocyte cycle, the incidence of miscarriage rate per clinical pregnancy is significantly reduced if paternal age is less than 40 years, that is 17.4%. Miscarriage rate in donor oocyte cycle is significantly reduced if paternal age is less than 50 years, that is 18.7%, and 24% it is quite high where the age is more than 50 years. The fertilization rate, the meta-analysis demonstrated that the odds of fertilization were not significantly greater if paternal age was less than 50 years. The cleavage rate, cleavage rate, odds of cleavage were significantly greater if paternal age was less than 50 years. The blastocyst formation, where odds of blastocyst formation were significantly greater if paternal age was 50 years. Top embryo quality, that is planned for transfer, odds of top embryo quality were not significantly greater if paternal age was less than 50 years. How should I remove this?
Go to screen share, ma'am.
Yeah. Now it is okay, no?
Still slides are visible, class, by the
Okay.
side.
So the random effect meta regression was applied to the autologous group for paternal age cutoff is less than 35, less than 40, and less than 45 years for two outcomes of live birth and clinical pregnancy rate. There was no evidence of an effect of mean maternal age on these two outcomes of interest for any of the three age of cutoffs. The paternal age less than 35 years log odds ratio of live birth rate for paternal age is increased by 0.14 for each additional year of mean maternal age. So paternal age less than 35 years log odd ratio for clinical pregnancy rate for paternal age is increased by 0.01 for each additional year of mean maternal age. The paternal age is less than 40 years. The log odd ratio of live birth rate for paternal age is increased by 0.24 for each additional year of mean maternal age. For paternal age less than 40 years, the log odd ratio for clinical pregnancy rate for paternal age is increased by 0.07% for each matter each. For paternal age more than 45 years, the log odd ratio of live birth rate for paternal age is decreased by 0.03 for each additional year of mean maternal age. For paternal age for less than 35 years, the log odd ratio of clinical pregnancy rate for paternal age is decreased by 0.05 for each additional year of mean maternal age. It is the largest comprehensive systematic review and qualitative analysis of the evidence on the effect of paternal age on ART outcome. It is also the first to assess potential association across 5 different age cutoffs for both donor and the autologous oocyte cycle. The studies included in the current review were assessed by the Validate Newcastle Ottawa Quality Assessment Scale, and the majority scored well, which suggests low risk of bias. So the maternal age is a confounding factor. The large varied data sets spanning a wide study period introduce significant clinical heterogeneity. The exclusion of non-English language citation, unpublished work, and abstracts in order to ensure data accuracy and reliability was maintained and may have introduced a degree selection bias. Now coming to the results. So how precise are the results? The studies included in the current review were assessed by the Validate Newcastle Ottawa Quality Assessment Scale, and the majority scored well, which suggests a low risk of bias. The result discussion is the analysis indicated a negative impact of increased potential age of clinical ART outcomes. Focusing on the primary outcomes in autologous cycle, a paternal age of less than 35 years, 40 years and 45 years was associated with statistically significant greater odds of clinical pregnancy and live birth than the paternal age of more than 35, 40 and 45 years respectively. The lower odds of miscarriage was also associated with a paternal age of less than 40 years. When analyzing donor oocyte cycle, there was no evidence of an effect of paternal age with cutoffs of 35, 40 and 45 years of ART outcomes. In autologous oocyte cycle, the only statistically significant outcome was a greater odds of blastocyst if paternal age was less than 40 years. The biggest confounding factor to consider is maternal age, as this will impact oocyte quality and rate of successful pregnancy. So now coming to section C, that is, will the result help locally? Can the result be applied to the local population? That is, yes. Where all important outcomes were considered? Yes, all the important outcomes were considered. This is a systemic review of meta-analysis, demonstrates a negative effect of paternal age at specific age cutoff on ART outcomes. This negative effect is less significant when donor oocyte are used and thus maternal age is controlled for. Thus, alongside maternal age, paternal age must also be considered when couples are planning a family. The conclusion is the reasons why advanced paternal age influences ART outcomes are explored in a number of studies investigating the impact of paternal age on sperm concentration, motility, volume, and morphology. The findings demonstrate an increase in DNA fragmentation, chromation, decondensation, and sperm aneuploidy rate with advanced paternal age. Thank you.
Dr. Anjum,
Yes, ma'am.
so since you have done the entire meta-analysis, you've gone through, if you have to do a similar study, what will be your exclusion criteria?
I will be excluding the paternal age less than more than 45 years, ma'am, because nowadays the marriages and all are becoming so late. So I will be excluding more than 45 years.
Why you will exclude more than 45? You want to compare age group, no, and outcome. Why should you exclude then? You should include it, no, so that you will have a better idea whether this delaying marriage and delaying pregnancy is having an impact. What are the confounding factors? What factors will affect your outcome?
Mainly age will confound, madam.
Whose age?
Both paternal and maternal age will confound, madam.
What is the meaning of a confounding factor?
What should be included, no?
No, what is the meaning of confounding factor?
I'm not sure.
See, when you have done the entire study, there are many, they have told, no, what are the confounding factors? Can anybody answer what is a confounding factor?
Factors which will affect the outcome of the result.
Yes. So what are the confounding factors in a study like this? How will you see to it that you decrease these confounding factors?
Advanced maternal age, ma'am.
Okay, so you will see to it that the maternal age that is included will
Because
be
chances are high.
so less than 35 is what you should consider for maternal age.
Yes, ma'am.
Okay, what else? What else?
Less than 30.
How will you see to it that the population that you have taken is only concentrating on paternal age? There are so many other factors that can affect the IVF outcome. No? So
Yes,
how will
ma'am.
you exclude those factors? How will you decide which is the population you want to select for this study?
When the female factor fertility tests are all should be normal and only
Go ahead.
so we should exclude female factor fertility, ma'am. Tubal factor, ovulation factors, everything. And if everything is normal, only if male factor infertility, if we include, then
No, even if you're including male factor, again, that can be a problem. No, see, if you're going to include patients, males who have severe oligoasthenozoospermia, they are known to have poor outcome compared to males with normozoospermia. So the semen parameters also should be similar across all the age groups.
if idiopathic, ma'am.
So like you have to basically consider unexplained infertility where all the male and female factors are normal.
Yes, ma'am.
Otherwise, you are having a lot of other confounding factors. So, Dr. Anjum, did you go through the studies that they have included? Were they randomized control trials? Were they, what was the sample size? Have they excluded female factors? Have they excluded poor ovarian reserve, previous IVF failures? Did you go through?
No, ma'am.
See, these are the things that will tell you whether this meta-analysis is actually a good one. If the confounding factors are very high,
Ovarian response in female is also a confound factor, madam.
so
Like-
sorry,
Ovarian response in female.
what do you mean by that? What do you mean by ovarian response? I didn't get
Nothing.
answer.
It's okay, ma'am.
I didn't understand what you wanted to convey.
Nothing, ma'am. Nothing.
Okay. Dr. Ankita, you have anything you want to contribute?
No, ma'am.
Okay. So, see you when. Hello.
Yes, ma'am.
Yeah. So I was saying, whenever you all decide to take up a study, you should understand how that is going to help us in our practice, whether it is a good enough study. See, just getting a meta-analysis is not going to help. You should see which studies have been included in the meta-analysis. Were they just case control studies, cohort studies, or were they RCTs? Which studies have more weightage?
Ma'am, randomized control trials.
Randomized study is more weightage.
Yes, RCTs have more weightage. So you have to see which kind of studies have been included. You have to see the sample size. You have to see whether the inclusion and exclusion criteria are properly followed. Because there are a lot of, when you're just selecting something like a paternal age, there is a lot of factors that can bias the study. So have they excluded those factors? These are the things you have to look into it. If the studies have not excluded those factors properly, then you're not going to get a valid outcome.
Okay.
Okay, and then have they excluded other male factors? Have they seen the sperm DFI for all the patients? Because
ma'am,
even in males, other than paternal age, there are many other factors that can affect outcome. Whether it was a normozoospermia or SOTS or OATS, whether the DFI was very high, whether they have other problems like other addictions. These all are going to affect the outcome, irrespective of age. Okay, so these things have to be seen and these things have to be mentioned when you're going through the study, because otherwise, if none of these things have been considered, then the study might not be, I'm not saying you have to totally not follow the study in that case, but you have to always be more critical about these kind of studies.
Okay.
Okay,
Yeah.
fine.